Hello everyone, welcome to Unit 3, the presentation for this particular unit in SEP 425. Well, today's actually a cloudy day, and so the first of the three units where I'm recording it, and it's not a beautiful day, so hopefully that's not reflected on your day here in this summer session. And this unit's a little bit shorter, that's why you're given a little less time to complete it, as there's a bit less content for you to go through. This is really now focusing on the post side. We've been through the factors that influence injury risk. We've looked at emotional reactions to injury, how to make referrals if clinical issues do arise in that initial reaction period, or even if they happen later on. And now it's important for us to spend some time on the issue of adherence to rehabilitation and looking at some of the theories, the research related to adherence, and then also some guidelines for improving or fostering adherence. And this is commonly a very important topic for athletic training staff members, and one area in which sports psych professionals might have a much better grasp of participant motivation, reasons for dropping out, continuing, than will athletic training staff or physical therapy staff. I've been commonly asked to come provide guest lectures to physical therapy programs within our own undergraduate athletic training program, and we teach an entire course at the graduate level on the psych of injury. So hopefully the folks here at WVU are going to get some good training in this area to make them better than folks in other areas. In this unit, we'll look at measurements, definitions and measurement of adherence. We'll look at some research on factors that are linked to adherence and those that are linked to dropout, and then we'll look at some interventions as well. Before we get into the content, you might pause for yourself and just think for a second about what would be some reason that athletes struggle to adhere to injury rehabilitation. You have athletes that you would assume, I guess, which is a bit of a naive assumption, that they want to return to competition, they want to get back to health as quickly as possible, that they trust their athletic training staff to provide them with all of the guidance that they need, that they trust that their coach is supportive. Why do you think some athletes struggle? What will be some of those reasons? Maybe if you're taking notes, jot down a couple. Or perhaps you see if you can make a mental note of what some of those reasons are. This is one of the big limitations of online courses is, of course, I'd love to have that discussion with you. Fortunately, you're able to do some assignments, and I can give you some feedback relating to the assignments in this unit that we'll get into later, and on cases we can kind of understand that, and a lot of the feedback will be straight from me as a professor back to you as a student, but unfortunately it's not as much of the discussion among students that can be so useful in the class. Well, let's have a look at some of those factors. If you need to know what barriers an athlete's facing, you simply need to ask them. So once they've been in rehab a week or so, maybe 2 weeks, it's a good time to set up a meeting, do a little counseling if you're an athletic trainer, or if you're a sports psych student or you're a counselor, you're serving as a sports psych consultant. By the time they've been in the rehab for a couple weeks, they'll have a fairly clear idea of what the barriers will be. And some of the more common ones you'll see listed here would be scheduling, certainly working with college student athletes, that's a common one. Convenience, location of the training room. Ignorance about how important it is to do rehab and how to follow particularly things that they should not do. There could be a negative stigma related to it. Maybe it's just a weakness thing, and they're very macho in their attitude. Could be lack of motivation. Could also be they're really not ready to do rehabilitation. One issue that's not listed here. There's a great article by Pizzari and colleagues on ACL rehab that talks about the fear of re-injury as a major barrier to completing rehab, particularly early on when that knee feels so sensitive and they don't trust it. So there's a fear of re-injury even doing basic rehabilitation exercises that aren't even really torquing the knee that much. So once you identify what the barriers are with an athlete, and this can be a conversation easily that athletic training students can have, coaches could have, as long as they're not overstepping their bounds and working as the athletic training certified athletic trainer, is identify what the barriers are and then help the athletes brainstorm about what strategies they can get around to deal with those barriers, because some of them are not going to go away immediately. So you can't, for example, change the convenience of where the athletic training room is, the time that it's available for them to rehab. Well, then how are they going to fit it into their schedule and do some basic time management? If they're dealing with a lack of motivation or they're not really ready to do it, then there might be some other cognitive stuff that could be appropriate. In terms of how we would measure whether an athlete is adherent, you could do this in a lot of ways. It's somewhat of a confusing thing. Attendance is simply not enough. And it's, a lot of work with certified athletic trainers over the last 10 years, I always ask them the question, if you could have what's the ideal rate of adherence? So if you gave them all of these things to do, resting, reps, sets, showing up, this level of effort, taking medication, all of those things, at what level would you think would be a really good? Do you want them at 100% doing everything, every rep, everything like that you ask them to do? And they generally say somewhere around 80 to 90%. So the idea is you give them plan A. Here is the whole set of behaviors you're being asked to do. And then if they're achieving 80 to 90% of all those things, they're doing a pretty good job of being highly adherent. There's been a ton of research in this topic in sports psych, and a lot of these things are fairly difficult to measure. Attendance is easy to measure. You can track sets and reps. You can, of course, have it recorded on the equipment you're working on in some cases. Effort is more difficult to track. It's typically through self-report or observation, whether or not they take medications at home or there. You can have folks rate how adherent they think they are. So it's a common way for sports psychologists to measure adherence would be to ask the athletic training staff that's working with them to rate, 1 to 5, how much has this athlete been following the instructions that you've given them. Another measure of adherence is, are they a good active patient? So are they asking questions? Are they engaged in the process? Are they giving honest feedback? Are they turning in self-monitoring forms from their home exercise that's true or not? And so some of these things can be quite difficult to track. And it's not to say that you need to measure all of them, but if you're starting a new training room or you're starting a new job, you should think about, what do I expect out of athletes, and what's the culture that we're trying to create here? And if you're a sports psychology consultant, you need to think about, well, what's realistic and what are you expecting them to do? And there's, what goals have they set? What do you expect out of them? And go from there really to figure out what's the appropriate way to deal with that. In a classic article, for those of you who are sports psych students or thinking about heading to graduate school, and you want to get into a deep, thick article from about 10 or 12 years ago, Brewer up at Springfield College did a review of previous research in this area of psych of injury and adherence, and there's been a lot of problems with the research up to that point. Now, there's been some really good research since 1998, but if you're reading evidence, and many of you got a chance to check out some evidence in the first unit, some of them do suffer from poor research designs, which basically means that their results may not be that valid. And so if you don't have a clear definition of what you're looking for adherence, you're not using a particular instrument that is well designed, reliable, and valid, and you have poor samples or non-random assignment to groups, now the research conclusions that you make are simply not that solid. Okay, so there's a lot of problems when interpreting the research in this area, but there are a few studies that we do want to have a look at. One other study that was done by Brewer and some of his colleagues up in Springfield College, they've done, I wouldn't be able to guess how many studies on ACL recovery and how psychological factors relate to ACL recovery. And one of the key things that they found were that the attributions of athletes were linked to successful adherence. So if you look at the bottom of this slide down here, those athletes that were successful at adhering to ACL rehab, which is a very long process, you're talking 6 to 9 months typically, can be longer for older adults, were reporting attributions that are internal and controllable. So they're attributing their success to things that are internal, in other words, characteristics of them, their effort, their work, their ability to do that work, and that are within their control as to how quickly or slowly do you think your knee is recovering. So they're all asked this question at the top, and then they're asked, okay, and then they code all of the responses at the athletes, and then they went to look to see, well, who was most successful at adhering, who was not. So some of the factors that came out among those who were successful were these: people engaging in rehabilitation, that's physical activity, maintaining a positive attitude, being determined regardless of the length of the rehabilitation. There's additionally some treatment factors they cited was linked to success, and that was the support of the therapist, a physical therapist in this case, the quality of care, support from family, and then there were some other factors that kind of went the other way. Severity of injury was, this is a serious issue, and many athletes, that motivated them to really stick with their rehab or listen to people because they were scared. So that emotion of being fearful then motivated them to be more successful. Now, if it was a recurrence of injury, that can go both ways. Sometimes that helps athletes be more mindful of what they need to do, and other times that creates more negative mood and frustration with the process. It's a nice little study that highlighted a few of the key internal controllable features that athletes can get into. Now, having a look at some other research, as you might guess, adherence is really not that good in all cases. And if you look across all the fields of medicine, adherence to taking medication, adherence to other types of rehabilitation programs, aside from just sport rehab, one of the classic studies done by ICE in 1985, you're looking at around 50% drop out of a variety of these programs, just like physical activity programs. And for long-term compliance, there's much worse long-term compliance than there is short-term, and that makes a lot of sense. It's easier to stick with a shorter rehab program that might last a few weeks or a month or two than it might be for a very long rehab program for a more severe injury. So compliance, in this case, compliance to the directions that were provided from a physical therapist is lower in longer-term programs. And then you can see in other studies, non-adherence, depending on the setting, can range from 10 to 60%. I mean, it's all over the map. In some of the work we've done here at WVU in the training rooms, we're dealing with a Division I situation here. And in many cases, coaches require attendance at rehabilitation. So if you're simply tracking attendance, if you look down at the Shell training room, a friend of mine, Kevin Kotsko, runs the operation, you're looking at a 95 to 99% attendance. So people show up. And if they don't, they go find them, and they figure out, why aren't you showing up? Now, how much effort you're putting in, your attitude, those other measures of adherence are maybe not assessed as often, but attendance, they're forced to attend. Whereas if you look in a physical therapy situation, you have to factor in insurance, how many times they're being paid, how often are you asking the person to come in, are they working a regular job, what's the travel like? There's so many other features and factors that influence whether folks are going to show up or not. So it's a lot of trouble, but it's an interesting question in terms of research, because I know from working with HealthWorks and doing some research over there that their bottom line is affected by folks that drop out or no-show. So they lose money on no-shows. They lose money on dropouts. And so they're very interested in factors that can decrease no-shows and dropouts at their facility. So even if the research here in sports psychology can make a difference of a few percentage points, you're talking about tens of thousands of dollars to a private facility. So this type of research, even small effects on adherence, can have a large financial impact for facilities. Some of the psychological factors that have been pretty consistently associated with adherence are basically negative mood, pain and negative mood. So negative moods refer to, from the previous unit, depression, anxiety, anger. Those emotional disturbances are negatively correlated with attendance. So if an athlete's having a negative, really poor mood state, then they're less likely to show up, particularly anxiety. Sorry for the interruption. Sorry about that. Getting back to our lecture. Also pain is an important factor, as you can imagine. And this is I highlighted these studies in green because they're done here by two of our PhD students, one supervised by Dr. Oster, another supervised by me, that found these two factors that were linked here in West Virginia. And these were both done either on WVU student athletes, and that was the pain, or on patients over at HealthWorks, and this is the age. So with the pain intensity, the more highly athletes were rating the intensity of their pain during a specific day or week of rehab was negatively correlated with them actually at being adherent, as rated by the athletic training staff. And we found also in the HealthWorks setting with older adults, more commonly working adults, that the older they were, the more likely they were to show up and be compliant, which makes sense because maybe they were a little bit more fearful, took their disease more seriously, or they have more time, because we did have folks in that age group that were retired and less likely to be working full time. Whereas younger folks feel better quicker, may not feel it's as important, or may have other responsibilities to keep them from attending. Just like anything in psychology, really, I mean, hopefully you got that from your 272 class. Personal and situational factors are often going to contribute, are going to be the biggest contributing factors in terms of groups of factors. So a bunch of personal stuff may contribute to their adherence, and then a bunch of situational stuff. So there's some examples here. So your individual motive and goals to recover and get back is one example of a personal factor. The athlete's personality, their injury history would be other personal factors. If you look back at your Weiss-Bjornstall model out of your textbook in Chapter 2 and out of Unit 1 slides, that's the same idea. And then another situational factor, just as an example, is your quality of relationship between the athlete and the sports medicine provider. So those are big influences, and just kind of linking back to those initial models from, let's not forget those from Unit 1. Some of the personal factors that in the research have shown major influences on adherence are here. Probably the most commonly motivated one is self-motivation, whether they're intrinsically, extrinsically motivated, and that they're confident and they believe in the efficacy of treatment. Another one that we really try to work on with ATCs is the perceptions of rehab and how that's going to go. So we've already talked about the idea of a cognitive appraisal in this course, and the athlete's perception of whether or not they can handle the injury and what the treatment process is going to be like. So in that case, it's very important to determine what's the athlete thinking about the injury, because that's something that they clearly can control, and it's internal. So you're really, as a sports psychology consultant, you're always looking for things that the athlete has control over, that they're responsible for, so that you can help them define their job when it comes to rehabilitation. And you don't want that then to overlap with the athletic trainer who's providing some treatment and is a supportive person, or the coach, or someone else. Like, it is the athlete's job to be resilient, to develop a way to tolerate pain, to learn about their treatment, to ask good questions, to be self-motivated. So all of those things are relevant. Now, if you're dealing with a younger athlete, looking at the last factor listed here, and this can be true of college athletes with their first injury, they may not have much experience dealing with pain, with loss, and so in this case, it may take them a little bit of time to adjust. They may be less flexible. And it may take them 2 weeks instead of 1. It may take them a month instead of 2 weeks. So it might take them more time because it's a new thing and it just scares them a little bit. So a lot of these factors have come up in the literature as potential correlates of adherence behavior. Some of the biggest ones related to the situation are the environment and the quality of treatment, and that's a perception of that. Also, the relationship between the athlete and the sports medicine provider, that's SMP there. So, do you trust this person? If you do, you generally follow them to the grave. You trust them, you do whatever they say. So this is where ATCs are in a much better position than sports psychology professionals, because you spend so much time around the athlete that when they do get injured, you already have a pre-existing relationship with them, so it makes it a lot easier. Whereas that relationship that athletes have with maybe a doctor or a surgeon is a little bit more tenuous. It's strained because they don't necessarily feel that comfortable with them, so they're going to lean back on parents, ATC, coaches, who may or may not know as much about what's happening relative to that. Other situational factors will be how long the rehab goes. We already talked about that. Are the finances an issue? Is the school paying for it? Do the parents have it? Is surgery an option? Because if they can pay for it, they'd get it. Do they have social support? And then any other psychological issues that were mentioned really in Unit 1, such as are they having threats to their identity? Are they lose their role on the team? Any of these other things that could occur when they're going to be out several weeks. So you always want to, if you're looking at an athlete that is adhering well or not, and you want to think, why is this happening? Then you want to look at, okay, what are the major personal factors going for them? And then what's happening in this specific situation that's influencing their behavior. So always factor in both. In terms of roles in facilitating adherence, I mean, athletes, as I mentioned before, are really responsible for all of their adherence behaviors. They're responsible for their, showing up on time, doing the work, following instructions, documenting everything. It's their body, their choice to rehabilitate that injury. Okay, the rest of us, sports psychologists, ATCs, we're only facilitators. We're basically highly trained tour guides. And the three main tasks that we provide, three main skills, I guess, would be educating about the rehab process. And so from a sports psych perspective, I would help educate athletes on what's a typical emotional ride look like if you're going to go through injury. You're going to spend a couple weeks being upset. You may be depressed, you may be down, you may lose motivation. That's normal stuff. So we need to educate them about that, just as an ATC would educate them about the specific things they need to know, and perhaps about the anatomy and physiology of it as well. Monitoring is one area in which we can help them, which is monitoring and tracking progress, giving them feedback based on objective criteria for how their pain is changing, how their depression is changing, how their strength, flexibility, range of motion, whatever the key outcomes are in that particular rehabilitation. And then, of course, we provide encouragement, and we are an ally. So if they need something, we're a connector. We help them find that person, find that information. We help them seek that out. So we should be a positive presence that teaches them new things, helps hold them accountable, and then provides a viable support person. Now, there will be some athletes that are inclined to be over adherent and do more, and you see this a lot in college athletes for sure who are motivated to return. They might be either pressed to return early. They really strongly identify with the athlete role. They're type A. There may be some large incentive to get them back to play, like they want to get back to play to impress a college scout or impress a pro scout. Or they're just totally ignorant and they're not really paying attention. They're just on their own. But it's typically the type A perfectionist who will go sneak in an extra workout and maybe undermining their rehab by not allowing adequate rest. So you do need to pay attention to that. And unfortunately, it's typically the athletes that you might think of as the ideal patient. I mean, they're following instructions. They seem ultra compliant. They seem super conscientious. They seem motivated. But then you just need to make sure that they're not overdoing it, because obviously if you're writing an exercise prescription as an ATC, you're not doing that so that they can do 150% of that. You would like them to do 80 to 100% of that. So if they're overdoing it, they may be doing additional damage. You really need to educate people about that possibility. Turning to measurement of adherence, a scale that was developed by Brewer and colleagues, as you're starting to get the theme here. They've done a lot of work. Britt Brewer and his wife, Judy Van Ralt, work up at Springfield College in Massachusetts, and they have literally written a book and written plenty of articles. I would not even guess dozens and dozens probably in these areas. And one of their contributions has been developing a very simple instrument that can be filled out by physical therapists and by athletic trainers to evaluate an athlete's adherence. And if you have a look at some of these items, they're rated across three things. This is a measure of their effort. So they're asked on how much intensity are they completing their exercises. So now you have something beyond just the attendance at the session. You actually have the intensity. You have how frequently they follow advice. So this is more of a compliance measure of, are they listening, are they doing rest, are they using crutches, and then how are they adapting when you change the program. So is the athlete flexible? And so basically these are all rated 1 to 5, You can get a score from 3 to 15, and then you would measure that at different points in rehab to get a score for adherence for that individual athlete. And you can track it over time. You can do it daily. You can do it for a week. And it's a very useful tool for collecting data for research purposes for psych of injury research. Now, tuning to the last part of this presentation, we want to focus on how to improve adherence. And so that really says we want to create an environment. We control, as the professional, only one part of this equation. As we mentioned before, the personal factors and the situational factors influence the individual's ability and their ability to adhere and their attitude towards the injury. So as a support personnel, as a sports psychologist, for example, working with an ATC, I really only control the situation. I control the environment, the physical environment, what it looks like, how I talk to them, the type of feedback I provide them, and then the type of interventions I engage them with. So some of the things that we might want to control would be help them identify barriers before they occur. We've talked about that. You can work with coaches to decide how you want to deal with attendance, and it's often very helpful to have a coach's power behind that, because oftentimes the ATC or the sports psychologist really does not have the say to tell an athlete, hey, you need to be here or else, because we don't have the ability to punish or to create some sort of set of consequences. Sometimes that can be a very useful role for a coach to make sure people show up. We do want to create some interesting information in the textbook, the Ray and Weiss BRSR textbook, on preparing the physical environment and what's the setup look like. So, for example, what's the space? Is there room? Is it a place that you'd actually want to spend time? And so some training rooms have undergone dramatic changes here at WVU. Like, for example, our shell training room used to be much tighter, used to be less than half the size, and now there's a lot more space in there. Even the lighting and everything else related to the physical environment we can control. You might remember from your 272 class what a task-involved climate is. This is, we want athletes to come to a training room, be expected to work hard, be expected to have a proper attitude, and to get feedback on an individual basis relative to those things. So we're not only working with athletes that are the big-time star athletes, we're working with everybody. We're developing individualized plans and giving feedback that encourages people to work hard and make progress. So that way, if you're having a slow progress athlete, a fast progress athlete, a starter, a non-starter, revenue sport, non-revenue sport, they're all really receiving reinforcement, and they're getting the right messages. And so this also refers to, this message issue refers to talking to athletes when they start to get down, or when they start to maybe have a pessimistic attitude towards it, is holding them accountable for that. So if they start to talk about, I'm never going to get back, you really have to challenge them. You say, what are you talking about? If you work hard, there's no reason to believe you won't get back. And, that negative attitude is only going to slow you down. A particular goal of sports psychologists, no pun intended, is to help them with their goals. So this is done somewhat naturally in the athletic training process, but in my experience working with ATCs, those goals often simply pertain to the sets, reps, rest, all the basic parts of the exercise prescription, and not necessarily to broader things about attitude, effort level, being supportive for other folks, involvement in the team, other external things that will really make their experience in rehabilitation a lot better. So I would encourage you to expand beyond the normal exercise prescription stuff when setting goals with athletes. Here's some example of sending the right messages. So the athlete might ask the ATC, well, how long am I going to be out? It's classic. Coaches ask it all the time. ATC's common response should be something along the lines of, well, how hard are you willing to work on your rehab program? It immediately implies a partnership with the athlete responsible for the effort in that process. I really like that part. When you're talking with athletes, be simple, be specific, what they can do, what's in their control, that they can focus on, and don't use jargon or anatomy or physiology unless that's something that they're interested in. Okay. Oftentimes when ATCs are explaining rehab and the injury to the athlete, they don't necessarily realize that they're not in a particularly good emotional state to learn. And so what I recommend is the use of written materials that follow up on any demonstrations that you've done, and then come back and review that after a few days to see if they retain that information, or quiz them on it. Okay, what are you going to do today when you go home? Right before they go, hey, what are you responsible for? See if they remember. They come back in 2 days later. Okay, how'd it go? Here's what we said you're going to do. How did it go? And then if they didn't do well, it's fine. Talk to them about what the barriers are. There's your opportunity now. So if you're talking with them and they didn't do well, go, okay, well, what happened there? You were supposed to ice 6 times, okay, just as an example, in 24 hours, and you did it once. So what is it about icing? Like, what kept you from completing that? And just start a dialogue with them so that they understand, yes, this is important. I'm going to hold you accountable to that. One way to keep athletes accountable is to let them have some control over the monitoring of the behaviors that we're expecting of them. So they might, for example, have their own calendar that they would bring in. It's not property of the athletic training room. It's not in a file somewhere that they don't see. They're responsible for bringing it. They see some basic stuff on there, and then they keep track of what they've completed, maybe any other measures of progress, of range of motion, swelling, flexibility, pain, quality of effort will be on there as well. And then this would also link with what do they need to do the next day, that night, etc. So they can track progress. They'll understand that not every day will be a perfect move forward or a path forward, but they're going to have some good days, some bad days, but in general they're putting a lot of effort in. And then that self-monitoring keeps themselves, basically just keeps them mindful of rehab at all times. So then they take it home, they put it on their coffee table. They see it while they're watching TV, and they remember to do their little rehab exercises at home. They remember to ice and prop it up, or whatever it is that they're being asked to do. So it'd be very short, 1 page, 2 page, simple, easy to fill out. I'm sure in the future, and I'm sure there may be available some applications that you can use on your phone. The problem with that is that it's not immediately accessible to them. In my experience, working with a simple piece of paper is better than almost any technology, simply because you don't need to log on, you don't need to remember it. If you physically put it in front of you, it's there. You cannot avoid it. Whereas if it's out of sight or in your pocket on vibrate, it's out of mind. Now, social support. There's a couple questions before we get into this. I think we all have a sense of what social support is. It comes in many different forms. So let's review those quickly, and then we'll come back to some of these other key questions. There's different types of support in the literature, and you should be familiar with these and be able to identify the types coming out of this class. Emotional support are things typically that's provided by friends, family, coaches, sports psychologists, and particularly peers. Maybe they've gone through the same thing. Informational support would be an example of ATCs, surgeons providing information for support on your options for surgery versus rehab, different types of decisions to make, when to come back. Tangible support, your teammates provide tangible support by giving you rides. There can be financial support from the school to get surgery. That's tangible social support. So these are the 3 largest categories of the types of social support. And then there's some research out there that looks at the perception of social support, so whether or not you perceive you have enough, and then the actual quantity of received social support. And there's been a ton of different literature to look at these 2 different things. Is it more important that the perception of social support? So I might have, for example, at school, 2 close friends that are helping me out versus a network of 15 people. And I feel like those 2 friends are doing a really good job of providing support. Is that enough? So research typically shows that the perception of social support is more important than what's actually provided. And you can imagine there's plenty of situations where athletes are do not feel like they're getting enough support, but really everybody's trying to help them. And so the received social support is not as predictive of actual success in rehab as is just the perception of something simple. Okay. So to answer the second question, do injured athletes really need support? Well, it kind of depends on the severity of injury. The literature here says that Support is most important at transitional periods in rehabilitation. So the initial injury, we need social support. We need information. I need emotional support if I'm dealing with pain or I'm going to be out for a while. I need help at that transition period. I might then need help in 3 weeks when I go get surgery right after that, or when I go home from school now and I still have to deal with injury. So whatever those transition periods are there, those are the biggest moments for the need for social support. Additionally, athletes might need support when they're returning to sport. So that's another critical period for folks to get engaged and check on athletes, check on their friends. So how do you assess if an athlete has enough? Basic answer to that is we know they have enough if they say they have enough. So if they really feel like, hey, I'm being supported, that's enough. We don't need to worry about how many it is, in my opinion, clinically. If they have the idea, yeah, hey, my teammates are supportive, good, they are. If they feel like coach is supportive, he or she is. So our job as ATC, sports psychology folks, is of course to provide positive support. And out of these areas, we're certainly going to provide listening and emotional support as a sports psychologist, informational support on the path of rehab, but we're not necessarily involved in providing tangible support. But we could on emotional or informational support as well. So one way to increase or to make sure that athletes do have the perception that they get enough social support is to encourage athletes to seek out other folks, and that could be other folks who have similar injury and pairing them up. That could be putting them in a support group. That could be encouraging them to seek out some other friends outside of the team. And increasing communication skills refers to assertiveness and helping athletes develop the skills to ask the right questions and going out to make other connections. And our role as helping athletes is really to be approachable, to respond when they ask for it, and give them time. And as a sports psychologist, hopefully we have no problem doing that. As an ATC, sometimes, of course, you're busy with other things, but generally they want that social support, and they rely heavily on the ATC oftentimes because you spend hours and hours with these individual athletes. And in my experience, the vast majority of ATCs are excellent in this area, just providing emotional listening support. They may not know how to do it for counseling, they may not be able to teach them sports psych skills, but generally in this area, ATCs are quite good. Another thing that is common in the literature is, as I briefly mentioned, just creating an injury support group that might meet weekly, where you would just get to connect with other people who are outside of your team context to just give you shared perspective, and that's kind of an important thing during that time period. So to review the assignments that are due during this unit, you have your reading quiz. You'll have some time to complete that. You're asked to do a reading reaction to the Brewer article. This is a pretty thick chapter, so it may take you a good hour and a half to read this article. So I want you to spend some time on it and give me a thorough reaction in the discussion thread. So just because it's a discussion does not mean it shouldn't be well organized. So check out the guidelines for this. And then also in your next discussion thread, you want to check out case study number 2 out of your textbook and post some of your responses to that. And then check out to see how some of the other students are evaluating that case study as well. All your work in this unit is due by July 26th at noon. And as always, please feel free to drop me an email with your questions. I'll be glad to help you out. Have a lovely day.